If everyone is here, then we will give the floor to the moderator. Mr. Facilitator, you have the floor.
Much. Our program director. I was here for 9 years as a member of parliament and chair of one of the committees.
Now what are you?
Now I'm a member of parliament. So she's asking me. I've been elected for 19 years now, doing my member of parliament. In any case, I am here to chair the afternoon session. And let me take this opportunity to give a salute to the regional director for the vice president of PAP, who I hope is around, and to the PAP chairperson for health, Honorable Zingas Kobelet, the honorable colleagues who are chairing committees in their own parliaments, and honorable colleagues from other parliaments. The representative for the AUC, Babem Bogazi, representative from the UN AIDS, and the reps from international partners and other health agencies. We welcome you. We hope we will be treated to fruitful discussions this afternoon. And I have heard a synopsis of all the panelists in terms of their background. And I'm confident that they'll do justice to the topic on health financing, sustainability, and commodity security. I think in the morning we know it was more about HIV and AIDS, but largely this afternoon is about how do we get to finance our aspirations when it comes to HIV and AIDS. So it's about financing now. I happen to chair the finance committee in my country, and probably I will share my views at the end when my honorable colleagues have done their round. Without wasting time, honorable colleagues, and again, taking into consideration of the fact that our lunch was a bit dragged, I will request my colleagues here, the panelists, to please bear with me when it comes to time. I will give no more than 5 minutes of each. 5 minutes, I think, and then I'll give the floor to my colleagues who I'll also ask to synchronize their own presentations. Without further ado, I would like to invite the Honorable James Goni, who is the Deputy Chairperson of the Committee on Monetary and Financial Affairs at the Pan-African Parliament. Mr. Goni, please.
Yes, thanks a lot, moderator. Ladies and gentlemen, honorable members. Actually, I just saw my name this morning because my colleague, the chairperson, whom I have great confidence in him, I thought he would be around, Honorable Mark Temple from Swaziland. Unfortunately, he's yet to arrive. I will just make a few comments regarding public financing, or what people call domestic financing in health sector. My background, CPA and accountant for the last, 30 years now. I've been in Parliament in South Sudan since 2005. A member of what they call Economy, Development and Finance. I've been a deputy for 7 years. I've been a chair for 2 years. I'm a member now there. And I'm a deputy chair here for Monetary and Financial Affairs. You would all know, PAP, and the special moderator would know, PAP is not like other parliaments or national parliaments because it actually does not have legislative powers. There's a new protocol yet to be ratified by member states where we can now actually make laws that can be binding on member states. Coming back to health sector funding from publicly generated resources by member states, and in particular AIDS, HIV and AIDS, I can only give example of what I know from our country, because the domestically generated funds tend not to go to HIV and AIDS, simply because the donors, some of them are here, tend to channel their funds to what they call off-budget financing. That is, programs, they directly fund the implementers outside the government budget. In our case, we have HIV and AIDS Commission since 2006. And as I told you, I've been in that government since then, up to now. I'm yet to see them to come to our committee to look for money, which means that what we have in the budget is just for their normal operations and salaries and so on, but their programs are funded outside budget. It is the Ministry of Health, the main ministry, that is actually suffering. And like other social services ministries, which tend to be weak within cabinets, they tend to be underfunded. And the infrastructure for health is actually run by the Ministry of Health, whereas donors tend to fund what is called consumables or commodities, medicines and the associated items. But if there is no health center and there is no clinic, and for that, for rural areas, there are no roads for urban people to go, these services tend to be over-duplicated where population is already being served. So it's a big challenge for member states to actually ramp up their work so that it could be complemented by donors instead of looking it the other way around. So with that, I thank you.
Thank you very much, Honorable Connie, the Deputy Chairperson of the Committee on Monetary and Financial Affairs, PAP. I move on to Dr. Chulata Onabajo, Regional Director, UNPFA, SRO, please.
Thank you very much, Chair. Honourable members, ladies and gentlemen, good afternoon. I should explain that I'm not Dr. Julita Onabanjo, but actually her deputy, Justine Coulson, but still very happy to be here with you. The theme of today's panel was really how parliamentarians can promote greater investment of domestic resources into health. And I think we have to start by thinking about what is the value proposition. Because investment in health isn't just for health. An investment in health is an investment in social and economic development across Africa. We recognise that 60% of the population are young people, and in our work with UNFPA looking at demographic dividend and how we work with countries to harness demographic dividend, it is very clear that if we only invest in employment and education, job creation, and fail to invest in health at the same time, we will not harness the opportunity presented by the demographic dividend. I'm not just going to talk about HIV/AIDS, I'm going to talk about sexual reproductive health generally, but we know that a significant burden of health in the continent is related to sexual reproductive health. The second largest cause of death amongst adolescent girls is HIV. 50% of new infections occur amongst young people. We see the huge burden on the health system of unsafe deliveries, unsafe abortions, and the complications and maternal deaths that follow that. But the argument for increased domestic funding is not just about an investment in economic development, it's also an investment in well-being and rights. So when we look at the commitments made under the Plan of Action for the ICPD agenda, when we look at the commitments made under the SDGs, it's very clear that there has been a global commitment to ensuring universal access to sexual reproductive health services and rights. And we can only ensure that no one is left behind, especially women, adolescents and young people, if we make that adequate investment. But the question is, why are we talking about domestic financing now? I've been around in the international development sector for 25 years. We've been talking about governments putting more money in for the last 25 years. But the reason why there is such an imperative now is when we look at the targets and commitments that we've made for 2030, but we look at the changing funding landscape, if we do not find new forms of commitment on funding, we will not be able to fund the achievement of the SDG 2030 targets. So we know money from traditional donors is reducing. And some of you will come from middle-income countries where you know that when that classification of middle-income country came and it seemed like a great moment, at the same time many traditional donors pulled out, even though many of those middle-income countries are carrying a huge burden of HIV. For example, at UNFPA, we're the only multilateral organisation investing in family planning and we're the largest procurer of RH commodities within the developing world, we have a $700 million gap between now and 2020. And if we do not fill it, we cannot reach unmet need for family planning and all the related complications that come for that for women who require those services. The other challenge we have to think about is just as the money is going down, the need is growing. So even though we've seen the family size reduce across most countries in Africa over the last 10 years, the reality is that most countries are seeing a growing population up to 2050. More people means more investment in health in order to ensure universal health coverage. So what can you do as honourable members? And I think that as parliamentarians who not only make policies and laws, but also really ensure the translation of laws into practice, that you have a unique role to play in terms of creating an enabling environment where we can ensure that governments are accountable to people. Parliamentarians have an opportunity to use commitments that are already in place. We have the Abuja Declaration. The Abuja Declaration says that countries will put 15% of their national budget into the health sector, and most countries across Africa do not do that. We can also advocate for investment in health as an investment in economic development. And many countries in Africa have now launched the Demographic Dividend Roadmap after the launch of the theme at the African Union this year. I think we can also stress the return on investment if we fund prevention. So just looking at my sector, family planning specifically, I know that for every dollar a government spends on family planning, they can potentially save up to $6 in their health system costs. And we can make the same arguments for investment in HIV prevention, in antenatal care, in safe delivery care, and health education. I think you have a unique position as members of parliament to bring the reality to national government. Your link with your constituencies, your links with your communities means that you really have an in-depth understanding of what your district health needs, your health facilities, your communities need, and you can really bring that up to the national debate to ensure you can leverage more domestic financing for health. And finally, I think governments are conveners or stewards of a total health system. And governments need to embrace the private sector as a partner in health delivery. But governments also need to set the terms of that engagement. And there's an important national debate to be had on who should pay and what they should pay for. So is it free health service delivery for all? Is it only certain services that will be free? Is it only certain people who will be able to access free service based on their ability to pay? Do we want national health insurance schemes? Do we want private health insurance schemes? Do we want to encourage out-of-pocket expenses? Do we want to contract out services to provide private sector? This needs to be a national debate. It needs to include the realities at community level, and there is no one solution. So for each country, there needs to be a nuanced package of health financing models that really relate to the reality of that country. Thank you.
Thank you very much, Ms. Justin. May I move on to Dr. Janet Biruhanga. She is the Senior Officer for Public Health. at NEPAD.
Thank you very much, moderator, for your kind introduction. Earlier, you did mention that you knew a lot about the people who were sitting on this panel. I don't know, we may need to introduce ourselves a little further. What I want to say before I make my contribution is just to simply introduce myself a little bit more than what the moderator said. My name is Janet Biarohanga. I've been working with the African Union Commission before I joined the NEPAD agency for almost a decade. So what I'm going to talk about regarding commodity security and locally produced products to address the HIV, AIDS, TB, and malaria, and other infectious diseases on the continent is something I've been doing for the last 10 years. And as the African Union Commission, we have developed a strategy to promote local production of medical products on this continent. But in order for us to achieve, to remove the hurdles that our manufacturers are confronted with, we needed to approach different, to approach the strategy in a way that we will address different packages of solutions and interventions using different models. So since this afternoon we're trying to discuss financing, I will focus my, my attention and my brief statement on how the African Union, in partnership with the NEPAD agency, of course, doing comparative mandates that we have, are trying to do to address the issue of increasing access to medical products. How are we looking at increasing access to medical products? How are we going to do that? The African Union, in 2005, I think the decision that we're talking about on Abuja to finance the health system with 15% of their budget started from 2005 when HIV, TB, and malaria were considered as a public health threat and an emergency at that time. It's at the same time that the local production agenda started. And we have been, along with the NEPAD agency, I mean, the African Union Commission, the NEPAD agency, and our partners have been working out a strategy on how we can strengthen the capacity and capabilities of our local manufacturers, especially the private sector, because most of the manufacturers are really in the private sector area. And in my statement, I would like to focus more on how do we make our private sector more viable to respond to this pandemic. We're talking about HIV, we're talking about strengthening healthcare systems. What in the healthcare system are we looking at? Because health system strengthening is broad. We're looking at the human resources, the skills base, we're looking at financing, we're looking at the governance structures, we're looking at the products in the system. We're looking at how we can make the system able to respond to the unique disease patterns that we're experiencing on this continent. And the only way we can do that is by sourcing solutions from within the continent. And today we have been talking about mobilizing resources, but how much are we talking about? When you go to the finance ministers and you give them figures, every sector in all of the ministries that we have convened in the AU requires the ministers of finance to or 2%, 1% this. So eventually the finance ministers find it difficult to allocate these percentages across the different sectors. So an integrated approach and a different way of thinking about financing is very important. And this morning when we're talking about investing rather than financing, that rang a bell in our mind, in my mind, to say that in my discussion today, I will tell you that the African Union is planning on establishing a fund that the private sector can borrow into, the local private sector can borrow into, especially those who have achieved the good manufacturing practices and are able to compete internationally, or maybe are just having a few gaps in terms of finances and accessing affordable capital to be able to advance in the area of manufacturing generic medicines that that will respond to the disease patterns that we're talking about, especially infectious diseases such as HIV. And of course, with the growing and emerging burden of non-communicable diseases. So this fund is supposed to be, the monies that are supposed to go into this fund are intended to come from different agencies, including member states themselves, to show that really we're determined to strengthen the capacities of our local manufacturers to be able to respond to our own issues. We are also looking at promoting this local manufacturing through strengthening our regulatory systems and harmonizing them. We have, for example, a program that looks at how the regional economic communities can work together to strengthen the national regulatory systems and to harmonize those across the region so that the requirements to register and market products that enter our jurisdiction are done faster and quicker, and they are harmonized so that the private sector who would like to engage in marketing their products, be it diagnostics, technologies, and different products, are able to do so in a timely manner, and also the patients are able to access these products in good time. The other thing that the African Union via the NEPAD is trying to promote is the domestication of the African Union Model Law on Medical Product Regulation. This law will help us to be able to put the right legislative environment for medical products to be regulated and to assure the quality and the efficacy and safety of the products that actually circulate in this continent. And so that we address the issues of counterfeit products that are entering our markets and also increasing the burden of the disease which is already we're struggling with. So in order to address these issues, the African Union is urging the parliamentarians here present, and also, of course, the other jurisdictions that are not represented here, to be able to be our advocates and ambassadors at the country level within your constituencies and across the other constituencies that are related with what we do, to be able to facilitate domestication of this law and to help us to reach the people we really need to reach in whatever category they are, be it the youth and so on. The other thing that I would like to mention before I close is the fact that the work that we are doing promoting local production is going to generate not only the access to products that are of good quality, but it's also going to trigger a lot of science, technology, because you know the pharmaceutical sector is quite knowledge intensive, so it will generate academia's knowledge to enter the industry and be able to be utilized. And so in that way, we can also use the youth that are unemployed and get them into to have a skills base that is adequate enough to respond. That we may not have. And what we're promoting here is to say that if we have a viable industry here, it can create wealth at the same time bring about good health. So maybe going forward, as maybe questions might come up, I may be able to articulate a little more in detail what the other opportunities and benefits of having a viable local manufacturing system would bring to this continent in terms of responding to the diseases specific, but also social and economically, what kind of benefits we could get if we source our solutions for the medicines that are required on the continent through a domestic industry. Thank you very much.
Thank you very much, Dr. Janet. I'm excited about the establishment of the fund, and I'm aware that there are quite a number of reps from the private sector who stand to benefit out of this fund. We are quite enlightened by them. May I, at this point, invite Dr. Daniel Molokele from SAPAM.
Thank you so much. If you fly with eagles, you'll end up not realizing that you're not an eagle. After some time, you'll just fly with them. I'm not yet a doctor, but it looks like I have to accept that I'm a doctor. I'm enjoying it. Maybe prophetically so, I might end up becoming a PhD doctor. So for now, I'll just swim with everyone else who is Dr. Who, Dr. Who. So I'm Dr. Daniel Molokele. I'm working with civil society. I have different heads in civil society, but the most relevant one here is that I'm coordinating the civil society platform on access to medicine in Africa. So it's the Pan-African Civil Society Platform on Access to Medicine. I'm also working with SAPAM, which is the Southern Africa Regional Program on Access to Medicine, as a technical advisor, supporting mostly the civil society component around that. So I think with SAPAM, I've been working with them since 2011. And one of the most important push which we've been having was that to get civil society into this space, and not only that, to ensure that there is a coordinated approach to addressing the issues around access to medicine, the strength that civil society has to support the other stakeholders. And one of the key stakeholders is the development partners. We've been working with the Global Fund, PEFA and others, and the UN agencies, all of their different heads. But also, we've also been trying to work with parliamentarians, especially SADC Parliamentary Forum, and so on. So it's an opportunity for us not just to work with UNAIDS, but also to work with the Pan-African Parliament to escalate, especially the issues around access to medicine from a continental level. I know that as a civil society platform on access to medicine, we've also reached out to the African Union Commission, the Social Affairs Department, and there's been a process of engagement because we are also monitoring the Pharmaceutical Manufacturing Plan for Africa, which is one of the most sophisticated documents Africa has ever produced, and is gathering dust as far as we are seeing it at the moment. And there's need for it to come alive and stop being a sleeping giant. I think for me, the most important arguments that I have this afternoon are two. The first one is that we need to look at health not just from a social point of view, because at this moment in time, what is disadvantaging health is that governments, political leaders are looking at it as a social concept. But in the context of the epidemics that we have in Africa, health is no longer just a social concept. It is a development concept. It is an economic concept. And so when we're arguing about funding for health, we start to use terms like investment or investing in health, looking at it from a bigger picture point of view to say that whenever you are discussing economics, whenever you are discussing development, health matters. And so people should stop looking at it as like a bottomless pit where you just throw money. Because what the epidemics are doing, they are actually undermining Africa's capacity to develop as a continent. They are actually ravaging the economies of Africa. So we need to look at health from that point of view, that is actually impacting the development potential of Africa, is impacting the economic potential of Africa. In fact, one of the obvious reasons why we need to think that way, let's look at the access to treatment concept, the ARVs. How much does it cost a country like South Africa to have access to treatment programs, and also to listen to requests for more people to be added into that? How sustainable is that? So instead of focusing on increasing access to medicine at that level in terms of access to treatment, where we know that most of the medicine that we have is not from Africa in the first place. Because someone said to me, Daniel, Africa is buying a lot of hair and a lot of medicine from Brazil and India, and this should come to an end. So one of the things that we need to promote, especially around access to medicine, is to look at Africa as a big market and start to internalize our strategy around that, to say we stand to profit more in the long term if we start to produce our own medicine, support the local manufacturing industry, and make sure that we as Africa take advantage of TRIPS flexibilities that some of our countries, LCD countries, can access, and make sure that as Africa, so as parliamentarians, I'm asking you that this is the lens that you need to push, that as Africans, let's start to domesticate even the market so that we can produce the medicine locally, because we're consuming the medicine from other continents, but we're not producing the medicine when we have the highest disease burden. Also related to that, from a civil society point of view, we are excited at the opportunity to support the parliamentarians in terms of technical support. Let's work together. And also the common responsibility that we have, that we are watchdogs, and also to make sure that in terms of funding for health, investment in health, from a budgetary point of view, we work together with parliamentarians, because we can support you as civil society to ensure that the lens that the governments are using right now of deprioritizing health, of ignoring the Abuja Declaration, which is not worth the paper it is signed on, that comes to an end. And we start to engage the treasuries, the Ministry of Finance, the reserve banks, the central banks, the development banks. We start to look at health from an economic and financial point of view. I'll stop here for now.
Thank you, sir. Thank you, Daniel. I'll make sure that I correct the document that was given to me. Now, the last by no means least, Dr. Ruth Mode, co-chair of 17.
Thank you very much. The African parliamentarians have indeed an obligation to fast-track the 2016 political declaration on HIV targets, as UNAIDS said. I totally concur with you. And I want to thank and applaud the AU and the UNAIDS for recognizing the role of parliamentarians they play in advocacy. This was very important, because you recognize the fact that a parliamentarian is a representative of a people, which means you can use them to create awareness. You can use them to ensure treatment compliance, because they have meetings. When an MP says you can't stop taking your TB drugs, communities listen, because that's the person they believe stands for their thinking. Or if you say you cannot stop taking your art medicine, it becomes important to them. Then you also recognize the fact that parliamentarians legislate, they make laws. All these draconian laws which are there, which are creating stigma, we created them, so we can repeal them. You also recognize the fact that we approve and adopt national budgets, which means we can actually stand up and say we insist on at least getting 15% of their declaration on Abuja. We have the position to even, we are allowed, the Constitution allows us to reject the budget and return it to the minister. Our problem is whipping. As a parliament, we play an oversight over the Ministry of Health. In my committee, last year, we summoned the minister 12 times. And every time you summon him to the committee, the room, there are more journalists than there are MPs, because they want to carry the story. Because of that, he has realized something, that he needs to work with the committee. Well, if he comes from some meeting, some high-level meeting, we immediately say, can I have 6 members of your committee? There's something I need to tell them. Because it's important. Otherwise, we'll be screaming when he's actually trying to do something. So what are the challenges identified as impediments for achieving the SDG goal within the parliamentary catalytic framework? I learned this way today from Sabelo. Number 1 is the funding gap. We have a problem with the funding gap on ARVs. Most of us are dependent almost on the Global Fund. I'll refer to the Zimbabwean situation. We put almost 80% of our Global Fund money towards treatment, by doing so neglecting other areas. Even then, if we are able to test and cancel a lot of people, it means the number of people who should go on ARVs will increase. That will create a funding gap which already exists. We have, even the testing and cancelling is no longer covered. And the reason why we put our money, all our money on testing, because we knew our government has no money to buy ARVs. We might play around with testing and cancelling through our own initiatives, but ethically, everybody has to remain on ARVs. So we held on to that. So our role as parliament is to galvanize domestic funding. We've been lobbying. We lobbied, I remember actively, then I was a director I was a civil servant. We lobbied parliamentarians then to ensure that the AIDS is the AIDS levy. Every Zimbabwean in Zimbabwe, salary, employed, pays a 3% towards a levy. And that money, when it gets to the revenue collecting authority, it does not go to treasury. That percentage, the 3%, goes direct to the National AIDS Council, who manage the levy. It has worked beautiful, because it has also attracted more money from outside. Then we recently also started lobbying for a health levy, because we felt the AIDS levy is limited to HIV and AIDS. We started lobbying for the health levy, And we successfully convinced the Minister of Finance. He has now put a 5% surcharge on airtime. So every time you buy airtime, 5% of that go, the mobile networks will submit to the Minister of Finance. Well and good. But our problem now as a committee is to say, while we are happy that we succeeded, this levy is still being managed in the Treasury, which means it can disappear, it can go to politics, it can go to elections, it can go anywhere where it's not supposed to go. So we have told the Minister of Finance that we need to come up with a framework almost similar to the AIDS levy, where the money comes from the revenue collectors direct to whether a body or whatever. We are also afraid to take it to the ministry because they are government. If you take it and give it to the minister, the president can say, hey, Pararenyatwa, where is that money? And he will definitely send it back. So we want something that can be audited by external auditors, that is everybody's eyes is watching what is happening to the money. Then the other problem, an impediment, is the commodity security, as my two colleagues have spoken here, i.e. the inability to produce medicines local. I'm of the opinion that, one, we lack political will. And as we stand today, I don't know, maybe South Africa only, there is no African country that can say they can produce competitive priced drugs. Because we have very high input costs, very high energy, everything is so expensive that the output will not be sellable. We have absolute machinery, manufacturing equipment. We have archaic technology. While in Zimbabwe you produce 100,000 tablets of cotrimoxazole in a month, China will produce 1 billion. So where will Global Fund and everybody else go to buy their drugs? They will go to where it's cheap. Because the name of the game here is price. And also the low medicine demand, there is always this thing about local things. You know, we are Africans. We believe what has come from Europe and elsewhere is better than what we make. And also, then the other one is the issue of leaving no one behind. Parliamentarians have enacted the evil laws that are stigmatizing KPs and sentencing part of the population to death. Hence, as parliaments, we have a moral obligation to advocate for the decriminalization of KPs and to ensure that they have access to services. In other words, we need, as a matter of urgency, to deal with the following. Legal we need to allow condoms in prisons. Let us learn from Lesotho. Zimbabwe is on its way. We are learning from Lesotho seriously. Whether we like it or not, it's happening. And we said we don't want to leave anybody behind. We can't leave prisoners behind because they are our husbands, they are our brothers. They'll come out of that prison. And then we need to revisit the issues around the age of consent. This is where my sister, my youth sister, spoke about. For us in Zimbabwe, because of the child law marriage, once we have done that, to ensure that we can then arrest anybody who marries a young girl, but we have created another problem. It means now a child, a girl who is 17 years old, cannot go to a health facility and ask for contraceptive because she's underage. She must come with a mother. When she's got an STD, she must be followed by a mother. Which African mother will take a child and say, here is my daughter, she's having an STD? No, they will not do it. And the child herself, being an African child, will never tell the mother. So now we have a problem. But in the Zimbabwe situation, we are reviewing the Public Health Act. So I've spoken to the youth organization that the parliament will be coming out to the public very soon. Make sure that you ambush every public health hearing and insist that the treatment, that change that law. Because we don't talk during public hearings as parliamentarians. We receive views. And they are all taped. It's a serious issue. Because later the public can sue for us not having done the right thing. I said ambush them, mobilize yourselves, and ensure that your issues come into that bill. So what I'm expecting is that, okay, we can't remove the model law, the SADC model law on marriage. But we can put a clause that says, if I'm a child and I'm now sexual active, then I should be declared an adult, at least as far as accessing health services is concerned. Something of that, I'm not a lawyer, something to that effect. And also parliamentarians must enact laws. I strongly believe this. We are looking for money here. We know there are a lot of capital projects that come into the country. Let's enact laws that say, because we know, for example, if you are building a massive bridge, there will be a lot of influx of, because your workers come from all over, they'll be staying in shacks, which means they can get TB, and everybody who wants money will move there. There will be a lot of STDs, sex, everybody will be there. So let us estimate that we think 10% of our budget from health will be eroded because of this project. Can that project ensure that 10% of the capital project goes towards health in anticipation of what is likely to happen? And then I have another issue. I really feel partners need to somehow galvanize and share information and know who is doing what within the region. And also, AU, you need to insist and say, every CCM, for example, the Global Fund country coordinating mechanism, there must be a member of parliament who's sitting there. Because the reason for sitting in there is to carry information and take it to parliament, is to actually inform your parliamentarians that, by the way, the minister has done this, which is wrong. Can we ask him during question time? But if you are not there, you don't even know what's happening with the Global Fund. In Zimbabwe, we sit on the CCM. It is a law. 2 members of parliament, 1 substantive, 1 alternate. We sit on the CCM. There's a project called the KP Reach, which is in the SADC region, Key Population Reach. It's important somehow to find a forum where all other MPs, other than those who are champions in these things, know about this program. There's the SADC Sexual Reproductive Health and Governance Project, which has been fantastic, but I think also it needs to spread a little bit. In Zimbabwe, we have started now involving more MPs by training them. The Parliament of Zimbabwe sits on is a member of the Key Population Forum at home, and that is an official position where every year somebody is appointed to go and sit there. Their duty is to ensure that they bring information back home, home being parliament, and they carry our views back to the KP Forum. The UNDP National Steering Committee, also on key populations. Parliament of Zimbabwe is part of the World AIDS Day Preparatory Committee. I am a member of that. We are preparing for the World AIDS Day through the National AIDS Council, but Parliament is part of that. Because when they go to the World AIDS Day, they are going to meet the people who elected me. So they must have me among them to say, oh, among us, especially if you see your districts, your constituents, they must say, we are happy to tell you that your member of parliament is here. It's called a strategy, a PR strategy, that one. And then there's what is called the NIAPACO. NIAPACO is a network for parliamentarians where we look at population control. This project has been running for years, and I've challenged the organizers, which is population development in Uganda, the IPPFs of this world. I've said, now, since you carry chairpersons of health committee to Uganda every year, why don't we expand this thing to go beyond population control? Because you would have already brought people together. Why don't we, instead of just talking about population, we talk about sexual reproductive, other things. We go on and talk about HIV. We involve UNA. People are already in one place. And there are about maybe 20 countries, which means that's 20 MPs, 20 parliaments. Then why don't we just grow it a bit? But I don't know whether it's, you know how even donors like their space. But I still strongly, and I'm strongly believing it can be done. Thank you.
Thank you, Dr. Labode, for such a very insightful and enlightening presentation. Honorable colleagues, before I yield the floor to your good selves, let me just pick one line from each of the panelists, like the one from South Sudan, Honorable Kony, where he informed us that in his country, all the programs are funded by international partners. Only the wages and other issues. Maybe let me just move on to what was said by Justin. she said something like, if we do not find funding now, why now? If we do not find funding now, even the objectives that we're talking about may not be realized. And she did highlight the fact that we should ensure that the laws that we pass in Parliament as MPs are put into action. This is the time. And then the Honorable I'll say Honorable Janet, there's no offense in that, being honorable. She availed the establishment of a fund which seeks to promote the private sector to borrow in this industry, particularly in terms of strengthening capacities of local manufacturers. I think that was great. Daniel Malokele, I'll not call you a doctor again. She said something very, very important to me and to us, really, that the issue we're talking about here is no longer a social concept, but it should be considered as a development concept and economic concept. I think that is very important. He urged all parliamentarians to work together with civil society in our respective jurisdictions, which I think is very, very important. Last, by no means least, but she said something very, very interesting, and I put down all the points. I'm very much inspired, Dr. Ruth, by the 5% surcharge, and of course it does have challenges which we are addressing, but for our country, I'm also inspired, and I think most of our colleagues will take it up and do the same in their own respective countries. The 3%, the 3% levy from airtime, is that right?
No, 3% is from salaries.
3% from salary, sorry, 3% from each member's salary to National AIDS Council. That on its own has actually provoked the international assistance from outside the country to come, because the international community has realized what Zimbabwe is doing. We're very much encouraged by that.
Thank you.
And we can learn from it. Honorable members, there are your panelists. I yield the floor to you. And I would request each and every member to remind us your name and country, or maybe your organization. Thank you very much. I start with you, sister, and over there is my sister there, another sister here, another brother here, and then there is Swaziland. I'll take the 5 for now.
Okay. Thank you very much. I'm Juliana Lunguza. I'm a member of parliament in Malawi, and I chair the Parliamentary Committee on Health. And I really like the reflection that has been given from the panelists here. And there are a few issues that I want to highlight. On the issues of local production, I remember about 3 years ago being in Zimbabwe talking about local production with our colleagues from NEPAD. 4 years down the road, we're still talking about establishing something. And this is one of the challenges that we have within the region, that, as Daniel puts it, we have so many plans on the table. When are we going to implement something? It's sad that within the African region, we have institutions like SADC, AU, NEPAD. ECOWAS are here, it's trying. To date, we are yet to establish that pharmaceutical company that every country can really benefit from. So walking the talk will make a huge difference in our setting as Africa. It's one thing meeting every July in Ethiopia. But where is the action on what we need to do? And what do our governments do? As a parliamentarian, I can keep on talking. But you, these organizations, you have the capacity to put our leaders together and drum these messages to them. So I'm hoping next time we meet, we'll be talking about doing it. And we've been crying that the private sector is left behind. This is the opportunity for the private sector to be active within our society. Thanks to India, most Africans could have died by now. We are all trekking to India, buying an air ticket, accommodation in India. We are making India rich. Why can't we do this in Muhimbili in Tanzania? Why can't we do this in South Africa? What is it that we discuss in these rooms that we do? I can do advocacy as a parliamentary chairperson in Malawi. But when you go to AU, when you go to SADC, these are the issues that you guys need to be discussing so that our leaders take it and really implement something. Otherwise, their talk is becoming stale. And my colleague from UNFPA talked about demographic dividends. We have all these young people. You have highlighted clearly, if we put up the pharmaceutical companies, we are creating jobs. Our young people are still out there doing nothing and doing the nyaopi the sister talked about, because we are not creating anything for them. So this is something that we need to think about. And while we are on these issues, I think it was Daniel who talked about 15% of Abuja declaration. I have challenges with NGO who are touting in our country that we need free health care to achieve the universal health coverage. Nobody should cheat us in Africa that we need free health care. And these NGOs, you as regional bodies need to start talking to these NGOs. Where do you think the countries will get the 15% if we are going to India to buy the services? We really need to smell the coffee out there. We can't continue touting free health care. And where do we talk about domestic financing if we are promoting free health care in our countries? And I remember was that in 2015, in Addis, we have the whole International Committee on Financing the SDGs. There's the whole issue of 15 to 18% illicit financial flows. People know where to get this 18%. We are struggling in these countries. Can some of these bodies try to track this money and bring it back to Africa? And while we are out of this, there's nothing like out of pocket. The mode for payment is not about out of pocket. We can't do out of pocket. When people are sick, they can't do that. Let's talk about healthcare financing through national health insurance, community health insurance. We have done it in some countries. The role of SADC, Pan-Africa, is to discuss what has worked, what's working, and how some of what other countries can model. While we are there, okay. Let me talk about the UN is talking about leaving nobody behind. We can't leave nobody behind if we think about everywhere we're talking about social cash transfers. We need to stop that habit of social cash transfer. It's spoiling our nations. Let's bring programs that are doing productivity, which brings to my agency, the UN agencies. You have been talking about delivering as one. If you put together your skills from FAO, ILO, UNFPA, the monies that you put in, you can put it into the productive sector, bring money into the countries, rather than just funding the advocacy meetings that we see everywhere. Those things, they are doing well, but we can do it to a certain extent. Finally, if we can't talk about health promotion, preventive health care, go back to the primary health model as Africa. We'll never get anywhere in Africa. Curative health care is very expensive. We have this youth generation. They need to know promotion. Thank you very much, Mr. Chair.
Thank you very much, Honorable Member from Malawi, Zikomo Kwambiri. Over to you, sister.
Thanks a lot, Chair and Excellencies, for this opportunity. I nearly forgot to remind you, I'm Lisbeth Mangati from the Department of Health. I just want to share South Africans' experience on the HIV and TB investment case that was shared by the Minister of Health, Dr. Motsoaledi, in Parliament. This investment case was essential in setting priorities and resources required for interventions in the fight against HIV and TB in South Africa. The efficiency of the country's HIV and treatment programs have significantly improved following this investment case. In the process, South Africa managed, with the support of partners, to reduce the price of world's leading viral load that was essential by then. Other enabling factors that help the country to move this far is community mobilization and creating demand for male medical circumcision. It really helped, and now it has been, the communities have embraced it. We know that South Africa has a large burden of TB, but South Africa is managing a cure rate for TB of more than 75%. How does it manage? South Africa has more than 45 units that are able to manage multi-drug resistant tuberculosis. South Africa also managed to accelerate use of technology that detects TB in 2 hours compared to the weeks and days by microscope and culture. This is indeed a political decision to be expanded. Same with malaria. I believe parliamentarians are aware that South Africa has managed to reduce the incidences and death of malaria by more than 90%. The focus is on optimal implementation of indoor residual spraying by using DDT. It works, and it works effectively. We know the politics and discussion around it is because I don't think people want this continent to be free from malaria, but DDT is working for South Africa. And we believe this country will be able to eliminate malaria much earlier than 2030, as outlined in our catalytic framework. May I end my comment by giving the Excellencies a take-home message that HIV targets will not be reached by prevention and treatment alone. It's a fact that HIV and treatment are difficult to separate. Therefore, a comprehensive combination package of HIV and TB prevention, intensified case finding, diagnosis, and quality treatment is required. Additional funding might also be required, but advocacy by parliamentarians can help. Thanks.
Thank you, Ma'am Mangate. May I move on to my sister, I think she's from South Africa as well.
Thank you very much, moderator. Firstly, I want to welcome all the presentations. They were all good. You know, I'm impressed. You know, but where I'm sitting, I'm asking myself, if we've got so many ideas, why are we not implementing? Because, is it money? Dr. Ruth, you are intimidating me. You know what, where I'm sitting, I was just listening to all your presentation. In fact, I'm interested to engage some of you together with my colleagues after this meeting, because I think they were very much helpful. I don't want to repeat what speaker number one have raised now, because it will be like I'm repeating what, as a politician, you know, politicians, they like repeating even if a person is covered. But I think we'll want to engage more on the 3%, 5% sachet. You know, it's good. Because here in South Africa, we still have another white paper on how are we going to fund NHI and so on and so on. I think what you presented is going to help us. Dr. Maisela and Honorable Tembekwayo, I think we'll have to engage you after this meeting. Thank you very much. Maybe even tomorrow. Yeah, it's fine. Thank you very much. That was a good presentation.
Thank you, Honorable. The Honorable Gentleman from Zambia.
Oh, thank you very much, Chair. As a parliamentarian, I think I have a few questions that need clarity in order for one to be an effective advocate in this particular problem. Well, first of all, there's no doubt that HIV/AIDS has been a devastating epidemic of high significant proportion on the African continent. And millions of our people have been affected, and we have lost them. And the question really, from a financial point of view, is what is the annual budget for HIV/AIDS activities in our respective countries? And are there examples on the continent where the annual budget for HIV/AIDS activities is brought to Parliament, specifically to Parliament, tabled before Parliament for discussion, for debate? Do we have such examples on the continent? And what are the strategies for raising the money, both locally and internationally? And is Parliament availed, that information for debate? And then how is the expenditure tracked by Parliament committee or committees to ascertain the impact, of that, funding? I think these questions are critical if parliamentarians on the continent, have to play a much more profound role of looking at the financing aspect of HIV/AIDS activities. I want to hear from the panel whether these questions I'm raising, are actually addressed in some of our parliaments, so that we know, how parliamentarians can actually stand vis-a-vis the challenge of financing HIV/AIDS activities on the continent. Thank you, Chair.
Thank you, sir. I give to Mabuza from Swaziland, and then South Africa, and then my brother, and then over there, in that order. Thank you.
Thank you so much, Honorable Chair, for affording me this opportunity. Please allow me, Mr. Chair, to start by maybe posing a question to Dr. Labode from my colleague from Zimbabwe. I'm also the chairperson in Swaziland on HIV and AIDS. The question is, what approach or what means or plans did they make to convince government to achieve their 3% from the workers' salaries and the 5% from the cell phones? That's a question. Then let me come to the case of Swaziland. Oh, I'm sorry, my name is Honorable Njabulo Mabuza. I just forgot to introduce myself, but good enough, the chair has already said my name. The only issue of the Abuja Declaration, Swaziland is really complying, and as far as I remember, we've gone to about 16% now, and that shows that government is, by all means, financing HIV and AIDS. We are now in the process of ending AIDS by 2022. That is, we are actually trying to stop all the new infections. That is also came out from the head of state when he was speaking to Parliament, officially opening Parliament the last financial year. And the government is working at really achieving that by 2022. There are some signs that that can do happen. I thank you.
Thank you, Honorable. My brother from South Africa.
Thank you, Chair. I'm Dr. Maisela. You can't spend money you don't have. You can only spend what you have. And you can't have if you can't produce. And we seem to lack the capacity to produce so that we can sell and get money. I think the former president of South Africa had a commission which tracked that billions and billions of rands and of money are siphoned from South Africa, from Africa to the former colonial masters, or from our trading partners, let's put it that way, or investors in our countries. Now that is the money that you can, a Pan-African Parliament should seize itself with trying to repatriate. I mean, if you achieve nothing else but just to bring that money back, we will wash your feet for having achieved this, because then we'll have money which rightfully belongs to us to spend on this, instead of forever having a begging bowl attached to our hip, or donors keeping on donating to us. They have something called donor fatigue. They may get fatigued. And what do? We will be crying like guinea fowls when they see human beings. So let us sit down and say one thing at a time, achieve it. If not, leave it. If it doesn't work, leave it, try another thing. Not do the same thing over and over again and expect different outcomes. So I think we are trying hard, but if you don't get any results, don't try harder. Abandon it and try something else, which will work. And I think you haven't, as Pan-African Parliament, sat down and say, not individual parliaments, but you are all here representing the continent. Why don't you just say, let's find ways of repatriating this money, just work on it for 6 months or for a year, so that if it doesn't work at the end of the year, we try something else. Maybe we can start achieving. By the way, education is the basis of productivity. If we can't give our children the type of education that will make them productive, and if we can't spend on education, we'll always spend on trying to cure something else somewhere. But the best curative measure is preventative. And to prevent that is to educate our children, not to be victims of those things. And of course, we have resources aplenty in Africa. What are we doing with them? We allow people to come and take them away. In South Africa, we have the longest train in the world that is carrying ore to the ocean and to the ships and come back. And then we buy the steel after the, yeah. Now, it is your duty as PEP to make sure that such things are looked into seriously, and instead of debating things that are not important. This, I think, is very important. Thank you.
Thank you very much, Doctor. Let me give you to the honorable gentleman, then I'll move on to you. Thank you.
Thank you, Mr. Chairman. Celestine Kumire with the SAPAM program. I would just like to add on what has been said about local production in terms of what has been happening on the ground. There is no doubt that the benefits of local production are there. I mean, within the SADC region, SADC Secretariat commissioned a feasibility study that was done in 2015, and it proved beyond doubt that there are benefits in local production. Now, one of the strategies that can also be used has been mentioned, that of the TRIPS, that is Agreement on Trade and Related Intellectual Property Rights, the TRIPS flexibilities to be applied. This has been agreed to. However, when you come to the ground, in terms of it being applied, not much has been succeeding. TRIPS flexibilities can benefit the SADC region in that there are a number of LDCs, the least developed countries, 8 of them out of the 15 within SADC. The advantages to that are that these 8 countries, least developed countries, are not obliged to implement TRIPS, and they are not obliged until at least 2013 to honor pharmaceutical patents. So that they should take advantage of that. India has been supplying generics to Africa. Now, in 2005, India is no longer allowed to be producing those same generics that are on patent. But these least developed countries can produce those same generics that are on patent without being subjected to these patent legislations. But what is required is that they must domesticate these TRIPS flexibilities into their national laws. Now, one of the reasons I believe that prevents this from happening is that countries do agree at regional level, but the moment they leave, going back to their countries, they revert to national sovereignty. That word, national sovereignty, which means things are not being done as a region. If there could be a regional framework that looks at domesticating all these instruments, I believe the continent could move somewhere. So let's move from national sovereignty to regional sovereignty and eventual continental sovereignty, where all these things are looked at earnestly so that implementation can be done. SAPAM assisted 7 countries to review their intellectual property legislation. But right now, it has not gone to the bill stage, whereby it should then be turned into law. If one were to then push that, and that's why I'm giving this challenge to the parliamentarians, in order to see that this is taken through to where it should go. In other words, being debated as bills, eventually becoming into law. And again, this should be linked to what Dr. Laborde said in the morning, the need to capacitate the parliamentarians so that they can appreciate and understand these benefits that the TRIPS flexibilities can bring about. That way, I believe they will be able to speed up the domestication and implementation of this. Thank you.
Thank you, sir, for the vital information on, particularly on TRIPS flexibility. It's very, very important. I know a little about it. My colleague up there, my sister, it's your turn now. Then I come to Malawi, and then the gentleman right here. Thank you.
Muito obrigada, Sr. Presidente.
Thank you very much, Mr. Chair. Lucia from Cape Verde. I would like to greet all the presenters, all those that made presentations. I would like to say that beyond financial resource mobilization, it is also necessary to have a larger coordination in the distribution and management of financial resources. I believe that if we, as parliamentarians, manage to promote dialogue between governments and civil societies, countries will win in the end. They will gain with a larger number of beneficiaries in terms of health care, in HIV particularly, concretely taking advantage of synergies. That's happening in Western Africa. As an example, between 8 countries, Cape Verde is part of these 8 countries. It's a project. This is financed by Luxembourg, where civil society has a very, very important role in what has to do with the promotion of health, introducing the issue of mobile units where people can access treatment at these health centers, and also the psychosocial support. This is assured by the civil society, so that there's a division of tasks between civil society and the respective governments. I think that would be one of the methodologies that we could support the respective governments in the management of financial resources. We know that the Global Fund is involved with most of the countries, but we're throwing somewhat in those that have medium income as a classification. So it would be a partnership with the civil society in order to allow civil society to assume some of the functions so that people who undergo ARV treatment may have an adequate diet. This in the absence of the adequate financial resources. If people, people may take ARVs, but they may not have the correct diet. This might be one of the methodologies that countries could take advantage of, following the example of the Project FEF in running in Western Africa at the moment, successfully. Thank you very much.
Obrigado. My brother from Malawi.
Thank you for giving me the floor. I've got 2 issues. The first issue has to do with the whole budgetary process. When you're approving allocations to the different sectors, I'll go back to the same issue about capacitating Parliament. In my Parliament, for example, I think we have 20 committees, but there are only 2 committees that are really charged or involved in issues to do with HIV AIDS issues. And that's the Committee on HIV/AIDS and, of course, my sister's Committee on Health. And when I received this invitation to come here, I was wondering whether the person was right. Am I really the right person to be involved, to be invited to such a forum? I I'm saying this because I think most of our parliaments are not really aware or on top of the issues to do with HIV/AIDS, including the speakers themselves. The speakers just come to open the function and they go, but they are not fully involved with issues on HIV/AIDS. I, as chair of the Budget and Finance Committee for 3 years now in Parliament, I don't think, I mean, I'm learning a lot of things here. I don't know much about HIV/AIDS. So the other 18 committees in Parliament, committees of agriculture, apart from health, infrastructure, and the like, they know very little, extremely little, on the issues of HIV/AIDS. So what I wanted to say is that as much as we can speak here as PAP, probably PAP hasn't done a good job in terms of capacitating Parliament. Probably UNAIDS hasn't done a good job in terms of capacitating Parliament. So this, I think, when you talk of issues of advocacy, comes first. And it's important that we put it on the top of the agenda. Secondly, last month, I attended a conference on Donor Coordinating Forum in Argentina. And this conference had to do with South-South and triangular cooperation of countries in Africa, for example, and those that are not in the G7. I mean, the North-South kind of the richest countries from developed to developing countries. And what I noticed is that, one, Parliament is not present at these forums, and two, that even this forum doesn't know that we've got this kind of arrangement. Because BRICS is part of it, and South Africa is part of it, and Africa is part of it. And here we are talking of countries to be producing these drugs. Each one of them, I mean, should be producing these drugs alone. And the honorable from Zimbabwe talked about economies of scale, the cost, the price, and all kind of stuff. So I think the right doesn't really know what the left is doing. Because with the Donor Coordinating Forum, the South-South, and the triangular cooperation, there are countries which are like in the middle income group, Brazil, for example, and you're looking at Russia, you're looking at other countries like Argentina, which are quite advanced in terms of technical know-how and technology. And what we're talking there was about transfer of technical assistance and transfer of technologies from these countries to countries like ours here in the sub-Saharan Africa. But these issues, I don't think are well articulated when it comes to our parliaments here. So I just wanted to mention that, and we think that probably there should be more research before we delve the resources. We don't have the resources in the first place. And there are banks in India, there are banks in China. Of course, the BRICS set its own bank to finance this kind of South-South and the triangular cooperation initiatives. Because at that forum, India was really hailed, for producing these ARV drugs. Thank you.
Muribanji. My brother, please.
Thank you. My name is Dr. Simaga. I'm working at UNAIDS in Geneva. I wanted to say, to let the honorable members to recall that the great initiative of our director, regional director, Catherine, just to see that all of the part of the institution are here. She bring the liaison office director for Addis, she bring myself and my colleague this morning, Badara from Geneva, the headquarters, just to show to you, to the African Parliament, that you are really here to listen, to learn, and to try to move from movement to action, as my neighbor was saying earlier, how we can action. Personally, it's the first time I met and I listened to the Pan-African Forum. I was very, very impressed about all the idea. In my plane, I just landed this morning, I prepare a speech and say, I will talk about A, B, C, D, D. And then I said, okay, first of all, Catherine trapped me because I'm a French speaker coming from Mali. How did I will express myself in English? That was the first challenge. And the second was, by the way, listening to you, I was like, okay, I have nothing else to say. They said everything. They are aware of everything. So it came again on how we move to action. And this is where is a question of chicken and eggs. Because at least, you know, we are saying that many studies are saying that, okay, the first challenges in the region like West and Central Africa, for example, but is in many countries, even in Southern Africa, is about lack or insufficiency of political engagement. And for us, political engagement is government, but obviously you. But then I heard also you said, hey, you guys from UN for organization, you are the one who can bring leaders together and then discuss about that. So it means what? It means that if we work hand in hand, then we can do better than us, each of us isolated. That's the first message, so how we can do it. The second point, being in Geneva, we used to meet your colleague parliamentarian from the north, and it's a little bit of what just my big brother say. Their problem is the following: how do we meet and discuss seriously with our colleague parliamentarian from the south? For two reasons. One, we have gained a lot of experience that we would like to share with them and see how we can help, for example, regulatory or other things. Second, we also are facing our citizens. We need to explain what good things was achieved with the first, let's say, international funds. And no one more than the parliamentarian will be more convincing. So it means they have a demand to have this cross or regulation work to do together about some key subjects that you mentioned. Then the third thing is, we are expecting from you that we can have a concrete action plan with you. I mean, about some key things like regulatory, you mentioned it. It's also, we are setting up an innovation platform where it's question of discussing regulatory is the same that the African fund bound that Janet just talked about few things. How to work differently with global funds. It's amazing that you couldn't imagine how implementers block is poor in global fund board to let the voice of the people. So you can help. I agree with Ruth that others can do. So in a nutshell, there are a series of subjects that we can work together, and we are ready. That's when we are all here. And the last thing is about governance. It's also about AIDS of isolation. Just to let you know that our director was just reappointed, maybe Catherine, only about AIDS, is also about what they call HX, is to manage or to coordinate all the UN agencies working on health. It means that the future is about having a health package instead of having this silo and verticalization. But how we can learn from AIDS, how we can take as a pathfinder good thing like multi-sectoriality, blah, blah. So all of that could be in a detail. But in a nutshell is, we are here to listen to you, but also to see how concretely we can set up some action before tomorrow. We can maybe have, I know it's in the agenda, but concrete, and we are really committed under our leadership, which is also Catherine and Michel himself, to do things. That's just a comment. Thank you.
Thank you very much, Doctor. Thank you, Doctor. Honorable Kalila from Zambia.
Thank you very much, moderator. First of all, myself, I would like to begin with a statement to say that I appreciate wholeheartedly the involvement of the African Union, United and UNAIDS, obviously, in trying to galvanize parliamentarians to remind their respective governments of their role, obviously, in the march towards the elimination and eradication of HIV and AIDS. I don't think that there's anything wrong, really, for the African Union, UNAIDS, in providing the necessary leadership to galvanize all of us around these issues. I was beginning to get a sense of feeling that maybe we were beginning as parliamentarians to lose sight of the fact that our role, obviously, as we have also been reminded, is oversight, budget support, representation, and those things. We know that it's incumbent upon the executives to do the things that we want them to do, but we are here basically to remind them, to monitor, to track, to ensure that best practices are being implemented, to ensure that, to question, and also to ask how they intend to raise more money, or why they are not raising more money or allocating more money to our health budgets. because, as my sister from Malawi has said, basically we know what works. I remember attending a meeting, I think it was organized again by the AO, Mr. Savelo might recall. We were talking about the Africa Health Strategy, the same catalytic framework, including the African scorecard for health financing. It was sometime last year or the other year, I don't remember. And we're all reminded that what needs to be done is to raise additional funds. And that, of course, it's not one size fits all, but one is obviously through increasing budget support, direct budget support, which is what most countries are following and have been following since time immemorial. It is actually from where this so-called famous Abuja Declaration of 15% came from. However, it was noticed that this is not enough. What came into play, therefore, was, of course, some form of levies, whatever you call it, AIDS levy or cigarette levy or talk time levy, and some countries are implementing these things very successfully, such as Zimbabwe. Of course, some form of insurance, whether it's community insurance or with national insurance like Rwanda. And then we know that some countries, of course, there's greater involvement of the private sector. So in short, these things are happening. Of course, they have been happening very slowly, and thanks to the African Union and UNAIDS, they are happening. What I feel where we are not doing well is on commodity security. It's much more complex. It involves the economies of particular countries, the legislation which my brother there from, I forget the NGO, which talks about medicines and so on. It's a little bit more complex, and perhaps the right approach is a regional approach. I mean, we don't expect every country to set up a manufacturing plant, but we can harness the regional approach. I think that's where we need to go. But some of these things are not happening in all the countries. I think this is political will. And this is where we come in as parliamentarians to ensure that we buttress these points to our respective governments, because we know what works. It's not working, because I think that in some of our administration, there is very little political will. Actually, personally, Mr. Moderator, I feel that as African governments, we have enough money to do this without even the involvement of foreign governments or NGOs. Having made those, I would now like to learn from those countries that have actually implemented some of these, such as Zimbabwe, especially when it comes to, I know that you have direct budget support, you have these levies, maybe you have also insurance of some form or another. I know Rwanda is not here, but I want to hear whether with some of these interventions in Zimbabwe in particular, whether you now are able to treat all the people that needs to be treated as a result of the fact that you seem to have more money now. You even have more money that has come in as a result of the this AIDS levy. I wish Rwanda were here also to share their experience, because they are doing the things that we are reminding ourselves to do. So I'm keenly interested. I know Zimbabwe is our neighbor, would be very keen to learn and implement some of those things. We are close to 1 million people, 800 or so now who are on treatment. I don't know how many you have. Of course, some of our treatment is still largely driven by commodities that we get from outside. But whether the introduction of that AIDS levy, insurance, direct budget support, you are now able to take care 100% your requirement for HIV programming. I think that's the only question. The rest were just my views or feelings over this issue. Thank you.
Honorable colleagues, ladies and gentlemen, I think you have all said a mouthful, and we thank you for your submissions. Now I would like to invite the colleagues sitting with me here. Maybe I'll start with what are you saying? No. May I give the floor to Dr. Chan, please?
Thank you, Chair, and thank you, honorable parliamentarians, for the insights that you have given to us to move forward with. I just wanted to respond to a few issues that were directed to the African Union and also to the NEPAD agency with regard to manufacturing medicines within the continent. The expectation here should not be that the African Union is going to put up a plant in one country and that plant is going to produce all the medical products that are required in the system. What the African Union is promoting is for African nations to create the enabling business environment for private sector to thrive. The African Union is promoting market integration so that the market is available for all the private sector to be able to benefit, because private sector is not going to invest in business that does not bring the monies that they have put in. So through the Continental Free Trade Area, for example, we're talking about bringing regional economic communities together and creating this one big market so that even for the medical products, we go the same way so that we are able to incentivize the private sector to enter into this business. We are also looking at creating an enabling environment for the human resources that will work in this business to be availed. We're talking about universities producing students that do not have the industry to work in. So if governments can create an environment where science and technology, health, education are speaking together and ensuring that there's coherence of these policies, we are working at a policy level to ensure that the policies that are in place actually favor local production. We're not talking about one country will wake up and do all of the areas for the continent, but what we are saying is that if there is a private sector that is running a local plant and does not have access to a certain market, how can we expand this market so that this company can be able to deliver and benefit from that investment? We're also talking about enabling the TRIPS flexibilities to be exploited. We need to build the capacities of the companies to be able to know, or the system to be able to know the IP laws that need to be put in place to enable the companies to invest in this area. Then again, we're talking about this technology transfer. We create platforms where Big Pharma and the other pharma businesses in the continent are able to have this conversation at a platform, a business platform, where we can be able to negotiate for this technology transfer. It does not come free. There has to be an environment that is created. So that is what the African Union tries to do, to incite governments to actually put in place incentives for the industry to be able to thrive in the environment. The fund that we are proposing to establish is not going it's a way of saying, look, the African nations, we believe that we can support our private sector, we can complement and make sure that maybe there is a way that they can access capital that's affordable without a big interest in it. Because right now we know that companies go to banks for loans, and it's very expensive for them because they have to pay high interest rates, and that is not favorable. Get the competitive advantage that we're looking for. We cannot be able to sustain, and that is why, to sustain the supply that is required, and that is why Global Fund will move into the other competitive companies in China and India who are able to bring in cheaper products. But what we're saying again is that we need to sacrifice. There is a sacrifice that governments have to take if we have to make our private sector viable. And we need to know that it comes with a price. We will not have cheap drugs come through from the level of the companies that we have right now. We will not be able to sustain it if we do not sacrifice and put the right incentives and time the incentives so that we are able to benefit from our local capacities. Secondly, we need to know that in the African the system right now for local companies, the way it's structured is such that the Global Fund, for example, is now looking into supporting domestic manufacturers. And the only way we can do that is to increase the volumes that our manufacturers are producing, to ensure the quality, and the space that we are creating as African Union to create the enabling regulatory environment is to ensure that at least our local manufacturers are able to register their products quickly because we have a harmonized system to regulate them, and we also have incentives from Global Fund, for example, saying that we can procure from the local manufacturers because they see we're trying to argue the fact that we need to do this locally. The more we move locally, the cheaper it may end up becoming. But of course, there is a price to pay initially for us to be able to become as competitive as India became. Because before India became what it is, there was a sacrifice that the Indians had to make. There was a sacrifice from the part of government to ensure that the private sector in this area particularly grows. And again, we're not saying that we're going to borrow entirely the Indian model, because right now, if you look at India, they are the pharmacy of the world, but they haven't produced access. I mean, it doesn't mean that because they have pharmaceutical products that they have resolved all the access problems to health products. It's definitely not the case. But the model that the African Union is trying to promote is one where we have a competitive industry that produces sustainable supply of the products that we require, but also we have created an enabling environment so that the products that come into the system are of good quality, they're safe, they're efficacious, and they're doing what they should be doing, and they're reaching the people in good time. So we will need to work with the parliamentarians to ensure that this model law, for example, that we're promoting, that it is domesticated, that national regulatory systems are strong enough to be able to capture the bad products from the good quality products and encourage the incentives and work as an incentive for business to be able to enter our market. So let us not put a lot of expectation on the part of the African Union, because the African Union is as strong as its weakest member state. If the member states within the African Union are not sacrificing time and resources into this sector, it's definitely not going to be successful at the African Union level. Will continue to compel member states. And again, the sovereignty issue comes in here, where the African Union does not have the authority to impose any policy among in the member states. So let us look outside our countries and move regional and begin to see how can we make this big market for our products? How can we integrate? How can we talk something collectively and go down to the into those are some of the key issues that I managed to pick up from the floor that I thought I would need to probably talk to with regard to what I had presented earlier. Thank you.
Thank you very much, Doctor. I forgot to remind panelists that now we are about 3 minutes. Now we move on to to Justin. Sorry.
Thank you very much. Thank you, Chair. Honourable members. Local production. So we've been looking a lot at local production of condoms, and there was an earlier comment about we talk about it a lot, but nothing's happened. What's interesting is there have been private sector manufacturers trying to move into local production within the region, and they have struggled. So we had a local producer or a local manufacturer of condoms in Botswana who's currently ceased production. We have a local manufacturer of condoms in South Africa that distributes or sells to government, but currently can't make the demand and needs to top up with products from other suppliers. We have another private sector manufacturer that wants to move into the market. So there is a growing interest in the potential of business opportunities for condom manufacturing, and I think for other medicines as well. The thing is, at the moment, to echo what Janet was saying, is the market isn't sufficient to sustain the private sector. Credit is too expensive. If you are buying products under certain donors, you have to buy products that meet certain pre-qualification standards, global standards. They're very expensive to reach. They take a very long time. And therefore, I think the question is, what can the region do through the regional economic commissions and other agreements to create a space for those new players in the market to have a confirmed guarantee of sales to allow them to go through that process of growth. In a former life, I used to work in condom sales in India. And the reality is the volume, the efficiencies and the cost effectiveness that comes with that volume, it is going to take us years for us to achieve that within an African setting. And therefore we must find some way of supporting private manufacturers to move into the market for local production. Otherwise they simply will fail, no matter how committed they are. The other comment I wanted to mention was just about primary health care, because we haven't really mentioned it today, and I think the Honourable Member from Malawi opened with it. That is a key area of focus for investment for prevention, whether that is HIV prevention, whether it is prevention around maternal death, other issues. And going back to the opening comment that the UN holds lots of meetings and doesn't actually do anything, there's a really great regional program going on at the moment, so led by UNFPA and UNAIDS, but also bringing up the UN partners on board, where we're really working with national governments to re-engineer how primary healthcare works to ensure a greater responsiveness to the needs of local communities. And it is not expensive. It's not about building lots of new facilities or having lots of equipment. It's almost taking us back to those basics of primary healthcare that, you know, we saw in the 70s and 80s, and making them better with the new services that we need to provide. Thank you.
Thank you, Justin. Honourable Connie.
Yes, thank you, moderator. I think I will be very quick. Local resource funding to finance health, in particular HIV and AIDS, it makes a lot of sense. One is obvious, economics, because for you to attain economic growth, sustain economic growth, you need well-trained workforce. And that workforce, it goes without saying that it must be healthy, isn't it? And therefore, it is in the interest of nation state in Africa to actually finance health. And I emphasized before, governments need to focus on health infrastructure, because if they wait for donors to finance it, it will never come. I've even seen that some of the programs, the funds up to 30% end up in some countries not being spent. Why? She just said it here. Because the processes, procedures, and the requirements, and what, pre-qualification, and so on, and then you reach the deadline that the budget life cycle is over, then you start over again next year, and so on and so forth. So the countries, if they do themselves, it's quicker to actually achieve results. And also my member of committee, professor, talks about expenditure tracking. I thought that's our primary role as parliamentarians.
Yeah, it is.
We don't but need to mention it here. Otherwise, what do we do in parliaments? AIDS funding, like there's a good office in Uganda Parliament where they have 2 or 3 economies simply try to track what donors pledge on certain programs and projects. And every quarter, they publish a report. They give it to all the committees in their areas of where these projects are being funded. And then they can take up with the agencies concerned, the donors, the NGOs, because it's very easy for donors to say, we've given this country X million of dollars. By the end of financial year, that money is not there. So MPs need to keep their eyes very wide open. Thank you.
Thank you, Honorable. Daniel Molokele, please, my brother.
I struggle to talk a lot because civil society at the end of the day is about action. The more we talk, the less effective we become. For me, the issue around how do we ensure that the national sovereignty factor does not continue to be an impediment to the development agenda of our continent is a very important issue. Because it also speaks to the Pan-African vision to say, in the context of Agenda 23, how do we balance us as a people moving forward? Because everyone can see that the advantage that China, the advantage that India have got, because they were also underdeveloped like us after the Second World War. What is the big factor that they're using in the past 60 years? Is population. They're using population, nothing else. That's their secret. Yeah, it's a game of numbers. In Africa, just by an integrated approach, we produce a multi-billion population. I think we end up being 1.2 billion, if I'm not mistaken. So where we're losing it is that we still continue to have our village mentality. We still continue to avoid working together. But the principle of life, which we all know as people of Africa, is Ubuntu, that we have to work together as a people, as a community. Kopano kimatla, unity is power. So umuntu abantu. That's what we believe as Africans. But it's funny that we are not learning. America's biggest secret is that it's a confederation of states. So they remove all those trade barriers, they remove. So America is just one big subcontinent. That's why any country in the world that has got the word federal or united has a better chance of survival. The Europeans themselves have got a European Union. Can you imagine if they followed Brexit strategy? Every country in Europe decided to exit. They will be weakened. So Africa's biggest challenge is to go back to Kwame Nkrumah's speech, where he was in 1963, looking forward to a new Africa, where we work together. And as Parliament, Pan-African Parliament, we speak to that vision. And the civil society platform, we are saying, let's work together to break down those national barriers. Because in the short term, they do not seem to be like getting down, being broken down. So we need to really work hard so that in the long term, we have an Africa that we are not saying let's dissolve the countries, but we are saying let's remove most of these trade barriers, the tariffs that we have, because it's easier for African countries to trade with their former colonial masters, like France and Britain, than to trade with themselves as neighbors, Zimbabwe and Zambia, which is tragic. 60 years after decolonization, 2 generations have been wasted along. So I belong to the 3rd generation of our post-independence Africa, and my dream is to see beyond my national lens, to say, can we work together as Africans? And the Pan-African Civil Society Platform on Access to Medicine wants to work with the Pan-African Parliament to move us beyond the rhetoric. The regionalization needs to happen. We know that in Eastern Africa, their parliament is much more stronger compared to Southern Africa because they can legislate. And we need to work together to improve the level of integration that we have, because even in terms of regulation of medicine, we talk about harmonization. So the more we work together, the easier for us to bring the prices down, to have a bigger market, and then be more effective, so that the local production, local manufacturing industry has a chance of survival. Otherwise, without a continental approach, they will not be able to survive. That's the way forward. Let's work together. And as Pan-African Parliament, let's prioritize that to the integration process, because it's taking too long and it's too slow and it's disadvantaging Africa in the long term.
Thank you very much, Daniel. I think that's food for thought.
Thank you very much. My first comment is on the professor from Zambia who asked us whether we know what the health budget is supposed to be. My answer to you would be, we do not know, because what we know, we do oversight on the AIDS levy, because it comes from government. We oversight whatever the Ministry of Health has allocated in the fiscus, but we cannot oversight what donors are using or paying for. They are paying for that, they are paying for that. Without it coming into the government coffers, we cannot do oversight on that. So it's very difficult to tell. It would need probably donors to say, okay, this is, give us information, and we take our information, we put it together. But all I know is that it is working somehow. Then there was a question on AIDS levy. Mabuza, you want to know how we managed to convince government. The AIDS levy did not come during the era of the Global Fund. If it had come now, the government would not have accepted. It came at the pre-Global Fund era when people were dying. Zimbabweans were dying. And the whole nation cried. There were demos on the roads demanding treatment. It was literally a revolution. And of course, ministers were dying. It was everybody dying. So government then said, we lobbied enough, and they said, okay, let's go ahead with this. And then there's somebody who said Zambia. Zambia then says, has this changed? Or are you performing any better? It's unfortunate that UNAIDS did not put up a graphic presentation or which country is doing how in Africa. Just as a good indicator, do you know that Zimbabwe achieved its MDG goal on HIV? Probably one of the few, and probably 1 or 2, 3 countries did in Africa, but we did. Our PMCT rates are sitting on 90-something%. It's evident that the work is there because I told you that when the Global Fund, the bulk of it, we put it towards treatment. So the rest, our money which is coming in, we are using it for testing, closing the tap. That's where the money is going. And this is why people always wonder when we tell them that we moved the whole country interacting with sex workers, interacting with LGBT community. It's because there is money from the National AIDS Council. The National AIDS Council organizes tours, visitations with the parliamentarians. Because there's money there, there's money which they can actually use. Because that money comes from the revenue direct to them. It's not even controlled by donors. They don't have to listen to any donor. They can listen to donor for other things, but this money which has come from government, they then can say, what else can we do? They have that option. And just to inform you that Uganda has been to Zimbabwe twice on the study tour, and about 10 Ugandans came. Kenyans have been, Tanzania have been, Malawi AIDS Commission with the HIV committee have come. They've come to visit, and now I want to invite those who want to come. Come again and see for yourself. It's nice to actually follow the process. I was actually telling the Southern African Eastern director here that there's no teacher like we have one. It's so important to follow the process than to be told. The whole story begins to sound fictitious. Where did we come up with the 5% for the airtime? People were sent to Ghana. Ghana, we copied this from Ghana. We heard about it, and then the Minister of Finance, he put people from the finance, health, parliament, he said, go to Ghana and come and tell us how exactly they've gone around it. So visitations are very important. You learn from other people. You listen to the little things, which the processes they went through, and you try to follow those processes. And then there was a question from, no, it wasn't a question, it was a comment from the Zambian finance budget, Zambia, Malawian. The Malawian budget, finance and budget chairperson. What you said about the rest, especially the finance and budget, they really need to be capacitated. There was a time when your counterpart from Zimbabwe, Honorable Chafika, because when we are presenting, when we are now going back to, when we are presenting to the, after the minister has given us the budget, there are comments that come from each committee, either complaining or cutting here or saying this, whatever. He stood up and said, we think the budget on health is too much because we have discovered they have this money from donor, they have AIDS, he was actually planning to cut our budget. But I understand where he was coming from. It was ignorance. But I'm glad Pan-African Parliament brought him here last time and trained him.
Oh, thank you very much, Dr. Labote. Honorable members, we have done well when it comes to time. We're supposed to be breaking off at 5 o'clock, and it's some few minutes to 5 now, some 2 minutes to 5. May I invite you to give a round of applause to these gracious panelists. And last by no means least, may we have a round of applause for all the interventions made here. Thank you very much. There is an announcement by the organizers that tomorrow we ought to be here at 8:30 sharp. So at 8 o'clock we'll be picked up from our various hotels because there is the official closing just before 1 p.m. 1 p.m. we should be gone. So that's the official announcement. So I hope we will not disappoint. Honorable members, good evening to you. Thank you.
Thank you.